Welcome to the Sicilian Secret Diet Plan podcast. This podcast is written and presented to you by husband and wife team Dr. Sandra Cammarata and Dr. Giovanni Campanile. Sandra is a psychiatrist and was born and raised in Sicily, and Giovanni is a cardiologist. They have written the Sicilian Secret Diet Plan book and podcast in order to introduce a wider audience to the wonderful taste and health benefits of the Sicilian Mediterranean diet, which will lead you onto a path of longevity and improved health span, the reduction of disease in the later part of your life. The goal is to live not only longer, but better with improved vitality and joy of life. Their motto is Be Well Deliciously.
Well, hello, and this is a special edition of our podcast from the Sicilian Secret Diet. My name is Giovanni Campanile, MD.
And I'm Sandra Cammarata, MD. And today I'm going to be interviewing my husband, Dr. Campanile, about a topic that he is very knowledgeable about. He has given multiple talks to the longevity medicine doctors, and he's an expert on lipids, cholesterol, which is a hot topic. Right? There's a lot of different strong opinions about cholesterol in particular, and what are the kind of studies that we need, lab studies, to need to monitor lipids and cholesterol. So we give the expert the word here, and I'm going to ask you, we start first with cholesterol, good or bad? Is cholesterol something we need to foster and elevate because we need it, or is something we need to be absolutely scared about and bring it down?
Well, first of all, cholesterol is essential for life. If we didn't have cholesterol, we would die immediately. We have trillions of cells in our bodies. The outer membrane of the cell is full of cholesterol. And so that's important for that. Our brains are full of cholesterol. Our steroid hormones are full of cholesterol. The steroid hormones and cholesterol are in the same pathway. In fact, everything derives from cholesterol. So one of the things that always comes up and a lot of physicians, practitioners, and patients bring this up is that what happens when we get our cholesterol too low? And there really is not a big correlation between the blood cholesterol, the blood test we do, and the cholesterol that's needed in those vital areas, like our brain, our steroid hormone, and the membrane. So, in other words, if we got the cholesterol in our bloodstream to zero, would it affect those areas? And it doesn't affect those areas. Those areas, because it's so vital, are able to make all the cholesterol they need.
So then the brain makes its own cholesterol?
Correct. The brain makes its own cholesterol. The cells make their own cholesterol, and the steroid hormone pathways make their own cholesterol. Now, this brings us to, why do we have high cholesterol?
Why do we check our cholesterol?
Right, because cholesterol is a major risk factor for heart disease. And the reason for this is that cholesterol lipoproteins are like little submarines in our bloodstream.
And what is a lipoprotein?
A lipoprotein is a spherical particle, and it's the big particle is what we call lipophilic versus because they cannot, lipids or fats cannot mix in water. Fat and water don't mix. So you need something to carry fatty things in the bloodstream, and that's what a lipoprotein is. It's a way to carry fatty things through the bloodstream to get to different places.
So if there was no lipoprotein, the cholesterol could not travel from different parts of the body to another different part of the body.
Correct.
Because it's not fat soluble.
So the way you should think about a lipoprotein molecule is that it's like a fire truck. When you have a problem somewhere, this fire truck takes off and goes to where the problem is and tries to take care of it. Now, the question is, why is our cholesterol so high? Is it natural or unnatural for our cholesterol to be that high? And the answer is, it's not natural. And if you look at modern hunter-gatherers, or if you look at babies who have a tremendous amount of cholesterol in their brains, their LDL cholesterol is around 20. While
What is it, the LDL cholesterol, before you go further? Because people know that we check HDL cholesterol, with everybody thinks is a good cholesterol, and the LDL cholesterol, which we refer to as the bad cholesterol.
And to a certain extent, that nomenclature is good, but it can be also misleading. So LDL cholesterol is the low-density lipoprotein, and that means that if you do certain testing, it has a low density, so it separates out in this testing process. So, and the low-density lipoprotein, LDL cholesterol, is what can get into the cells and cause atherosclerosis. If you look at an atherosclerotic plaque, which is a plaque, a buildup of atherosclerosis, and this, by the way, is why we even care about cholesterol, is the buildup of a plaque in different parts of our bodies, like our heart arteries, the coronaries, our carotids, because they can cause stroke, they can cause heart attacks, they can cause kidney failure. So we don't want the plaque to build up. We don't really care all that much about cholesterol, but we know by many, many studies that the LDL cholesterol is conducive. The higher it is, the smaller the particle, the number of particles, and a way to measure that is with this apolipoprotein B, which is an indirect way of measuring the number of particles. So if you have a large number of these particles, they can get into the cells and cause damage.
So this is the bad cholesterol.
Right.
Does HDL cholesterol cause also damage or not? Or is that protected? Why is it called the good cholesterol?
HDL cholesterol is the high-density lipoprotein, and this is usually protective, but there's newer data showing that if you have very high HDL cholesterol, it could be dysfunctional. So this is why we do some additional testing to look at the quality of the HDL cholesterol and to look at the functionality. It's very hard to measure because cholesterol comes into our bodies, and there's three ways that cholesterol goes into our body or in the bloodstream. One is produced by the liver. Two, there's receptors in the colon that hang on to saturated fats and cholesterol. And then three, there's a process called reverse cholesterol transport, where the cholesterol is eliminated from the cells, brought back to the liver, there's LDL receptors, and then eliminated from the body. So this balance of these three mechanisms is what results in our cholesterol levels.
So you said when HDL cholesterol is high, is too high, is also not a good thing. What numbers are we looking at? Because a lot of our patients come to us and say, my doctor told me that my HDL cholesterol is high, so that is good, that is protected. What is too high?
So more recently, we have been looking at advanced lipid markers. And the reason why we look at these other advanced lipid markers is because they're more predictive of future risk. And we used to say HDL LDL ratio, if the HDL LDL ratio was good range, then you have very little risk. But now we know that if your HDL is too high, and too high meaning above 80 milligrams per deciliter, that it's possible, not necessarily that way, but possible that it's a dysfunctional HDL, in which case puts you at higher risk, not at lower risk. So you really need to know all the factors. And one of the ways to simply look at this, and then there's the other confusing factor, is that and the nomenclature is actually very confusing. There's lipoprotein small a, which is a genetic factor and very contributory to atherosclerosis. It's a bad player. And then there's lipoprotein capital A1, which is a very good factor. So it's confusing. So one of the best measures of your risk of developing atherosclerosis is looking at apolipoprotein B divided by apolipoprotein capital A1. And that gives you the B A1 ratio. And what we look at is anything, the cutoff is 0.6. If you're above 0.6, you're probably going to develop plaque. If you're below 0.6, you're probably not going to develop plaque, or you could even reverse disease.
So the majority of doctors do not check apolipoprotein little a. They do not check apolipoprotein big A1, and they do not check apolipoprotein B.
Correct.
Should we do that or not?
I think so. I think that at least once you should get a lipoprotein small a checked, and on a regular basis follow apolipoprotein B. Now, there is some concordance between apolipoprotein B and LDL, which is easier to check for. But apolipoprotein B is much, much more predictive. So if you really want to know if you're getting your risk down, in my opinion, you need to check the apolipoprotein B. Because if you have coronary disease, and we now have sophisticated ways to see if one has coronary disease or not. We use a test called Clearly, which is a CAT scan with contrast with artificial intelligence overread. And we can differentiate between calcified plaque and then non-calcified plaque. And the non-calcified plaque is divided into inflamed and non-inflamed plaque. So this is very important because where your non-calcified plaque is, and if it's inflamed, is a big deal. And it will determine how low we want to get your numbers, especially the apolipoprotein B.
So if you have a genetic predisposition for heart disease, which is probably detected and determined by the presence or absence of apolipoprotein little a, I'm assuming you have to be a little bit more aggressive when you see an elevated LDL or an elevated apolipoprotein B. What would you recommend your patients that come into your office with a slightly elevated cholesterol, but with an apolipoprotein little a present versus a patient that comes into your office with no genetic risk factor and still an elevated apolipoprotein B or LDL or both?
Well, first of all, you want to know, is any of this causing damage? And that's where the testing of the plaque in your arteries. Because there are some people with elevated numbers, but they have no plaque. They have zero plaque. So in those patients, you don't need to be super aggressive. On the other hand, there's 3 coronary arteries. There's one on the right, 2 on the left. The one coming down the front of the heart is the LAD. If you have big, bulky plaque in the, I don't like this name, but it's called the widowmaker area. And the reason why it's called the widowmaker area is because if it ruptures in that area, you don't usually survive that heart attack. So if you have big, bulky plaque in the widowmaker section of the LAD, and you have elevated lipids, and you have elevated LP little a, then you have to be super aggressive in lowering the numbers, really super aggressive. And that's the difference between someone has LP little a elevated or not, is how aggressive you are in lowering the ApoB.
So what are we talking about? What is being aggressive? Are we giving a stent? Are we giving medication? Are we encouraging lifestyle changes? What would you recommend? What do you recommend usually to your patients once you know you get the blood work slightly or high elevated cholesterol, especially the lipoprotein B, possibly lipoprotein little a, some heart disease in some plaque formation in the test that you order, and now what do you do? What is an aggressive way of treating that patient?
Well, the first thing we do is lifestyle change. Make sure the patient is on a healthy diet, exercising, reducing their stress, sleeping at night. We have the old American Heart Association Simple 7, which are getting rid of cigarette smoking, lowering cholesterol, lowering blood sugar, lowering blood pressure, making sure you're on a good diet, exercising, and
sleeping well.
And sleeping. Well, that's simple 8 now, sleeping well. So now we have the simple 8. So those things, that goes without saying. You have to do those things first. Then we look at medicines. There's statins. And if you Google statins, you'll get all kinds of information all over the place, good and bad. And some of the information is not quality information. So I'm a little hesitant to have my patients Google the benefits of statins because the information...
Patients will do that. Yeah. So how do you guide your patients to understand what is a good study and what is that the scientist and the expert behind this specific treatment, heart disease treatment, will recommend?
So the main thing when you treat cholesterol with a medicine is that you don't want to just lower the cholesterol. You have to have good clinical data stating that it lowers outcomes. It lowers heart attack risk, lowers stroke risk. So the medicines that actually do that, we have a great armamentarium of medicines. We have statins that work quite well with low side effect profile.
Statin have always also been now considered to be helpful in possibly reducing not just heart disease, but dementia risk, and possibly also helping overall health span.
Well, this is what we call pleiotropic effects of statins, and that means the good side effects. The good side effects are they're anti-inflammatory, very significantly anti-inflammatory. They're antiplatelet. They help the inner lining of the arteries is called the endothelium, so they help endothelial function. And in fact, during COVID, patients on statins did not die from lung disease like patients off statins because of the anti-inflammatory effect. And then there's a meta-analysis looking at dementia risk. Patients on statins have less dementia than patients off statins. Now, there are side effects. Muscle aches in about 5% of the patients. So 95% of the patients do not get it, but 5% do. And they can increase blood sugar. So, and they can cause type 2 diabetes. So, these.
What is the percentage of that? You said about 5%?
5% get muscle aches, and a small percentage, less than 5%, get diabetes.
So what is your recommendation about once you put a patient on a statin, how often do you monitor them for diabetes, for elevated blood sugar?
Frequently. And in fact, a question I frequently get is, if you have diabetes, should you go on a statin? And the answer is yes, because diabetes is such a big risk factor for coronary disease that you really need to reduce it. But fortunately, we're in an era that we have newer drugs.
So if one of your patients cannot tolerate statin or increases, or their blood sugar increases, what do you do next?
Well, there's a fascinating discovery by a woman named Hobbs. Her last name is Hobbs. And she found a group of individuals that there's a molecule in our body called the PCSK9 molecule. And this molecule, what it does is it degrades the LDL receptor. And if you degrade the LDL receptor, what happens is the LDL stays in your body longer. This is called residence time of the LDL. And if the residence time of the LDL goes up, then your overall risk goes up. So she found a group of individuals that don't have the PCSK9 molecule. And these people have LDL cholesterols of 20, as opposed to the average American that's over 100. And none of these people, not one, had heart disease of any sort, no coronary disease. So this led to the development of a PCSK9 inhibitor, which is an antibody to the PCSK9 molecule, which results in increased LDL receptors and elimination of cholesterol from your body more readily, and lowering cholesterol, LDL, ApoB, significantly enough to reduce, and studies have shown it reduces the risk of heart attacks and strokes. So this is and it doesn't have as much of a side effect profile as statins have.
And what is that medication?
Well, there's two. Repatha is the main one, and then there's Praluent, which is the other one. There's two out there. But this medication has to be done with an injection. It's like an EpiPen. You do it twice a month, and with great results.
Oh, sounds like life-saving, truly.
Now, there's other newer medicines coming out. There's a medicine called bempedoic acid, which is like statins, an HMG coenzyme reductase inhibitor. But it works, it's a prodrug, and that means that the medicine you take it has to be activated before it works. And it gets activated only in the liver. So
has to be ingested,
goes to the liver, gets activated, and it works only in the liver. So that's the main benefit compared to statins. Statins work all over your body, including all your muscles, while bempedoic acid only works in the liver, and it reduces your cholesterol. Not as effectively as statins, but pretty good, and they also reduce outcomes. There's another medicine called inclisiran, which is a remarkably interesting drug. It's an mRNA PCSK9 inhibitor, and you get an infusion of this once every 6 months, and it keeps your LDL cholesterol super low.
So we're talking about all these wonderful medications that continue to be discovered with less side effect profile, can decrease negative outcomes, improve quality of life, and decrease the chances of developing heart attacks, strokes, decrease inflammation overall, and lifestyle always comes first, right?
Yes.
To be able to maintain a good lifestyle over time, decrease stress, diet, all of this. Now, tell our audience what is that a functional medicine doctor like you does in terms of preventing all of this from happening. What is your suggestion to a young person that comes into your office, a middle-aged person that comes to your office, an older person comes to your office, and do we look at women and men differently in terms of cholesterol, in terms of the risks for heart disease, dementia?
Well, first of all, we don't look at women and men differently because the cholesterol reduction is the same for women and men. What's different about women that's very important is that women have different symptoms. Women can present very atypically. Instead of having the classic crushing chest pain, if they're having some kind of problem, they could have shortness of breath, they can have fatigue, they can have just night sweats, that sort of thing. I mean, men can have those too, but women tend to have atypical symptoms more frequently. And then the other issue with women is that, women are smaller than men, their arteries are smaller than men, so they tend to have worse outcomes if they have a heart attack. Because there's less room to work to take care of it, things like to put a stent in or that sort of thing. So, I think we have to be more proactive in women because of that issue of having higher risk if they have an event. If a woman has an event, she has a more high likelihood of having a very bad outcome compared to men.
So a lot of people are going to ask you, can I just take a supplement? Why do I have to take a medication? Are there supplements that can help to reduce cholesterol, apolipoprotein B, LDL?
Yes, absolutely. And that's why we risk stratify. If we see someone has either no disease in their coronaries or they have very little, that's why a test like the Clearly test is very helpful. It's helpful if it's normal, and it's helpful if it's abnormal, right? So if it's normal-ish, not with a lot of plaque, then we can take a more casual and lifestyle approach. And there are very good supplements out there that help lower cholesterol, like red yeast rice, very effective. It's basically reduced rice is a natural statin. In fact, the original statin, lovastatin, was basically reduced rice. And so in some patients, it lowers cholesterol quite effectively. And then there's other medicines like bergamot, which is a extract from a citrus plant from southern Italy, which also works like a PCSK9 inhibitor in some patients. And berberine, same thing, also works like a PCSK9 inhibitor. And then other supplements like olive leaf extract, garlic. I also give my patients foods like a Mediterranean diet, but also a combination of olive oil and garlic in high concentration, and sometimes capers, which lowers cholesterol. So there's some natural ways to lower cholesterol. Fibers lower cholesterol, like good fibers, like water-soluble fibers like oat bran, like from oatmeal. And then this brings us into the whole concept of the microbiome. If your microbiome is very much associated with your cholesterol. So, having a good diet and a good microbiome with fermented foods and a variety of fibers is very important to maintain this balance.
So, Dr. Campanile, very happy to hear your expertise on a very, very complicated and controversial topic like cholesterol and lipids. So thank you very much.
Oh, you're welcome. My pleasure.
If you are new to the show, welcome. And if you are returning, we are so grateful for your participation and support. We hope you go to iTunes or Spotify and subscribe to the show, leave feedback, write a review, or send questions. They love questions and look at every question that is submitted. The content of the Sicilian Secret Diet are meant for educational purposes only and are not meant to be a medical diagnosis or treatment advice. A doctor-patient relationship is not created, and any questions related to your specific physical or mental health should be directed to your healthcare practitioner. So hello, and thank you for joining Sandra and Giovanni for another episode of the Sicilian Secret Diet Plan podcast.